So today I'm going to talk about something a little bit different from the typical thing in epidemiology, like a study design or the indicator. Today we are going to introduce the other thing, which is about the tools of diagnosis tests and the screening, and how we are going to evaluate the performance of those tools. Outline. So first of all, I'm going to remind you the idea about how we apply the knowledge from biology as a science. Of course, biology is one of the disciplines in science. But now we consider it in the application for a big scale, especially focus on human beings for their diseases. And then I will introduce some ideas about the differences between diagnosis and screening. The process might be the same, but the purpose might be different. And also we might need to modify them a little bit based on the characteristic of the tool and also characteristic of the population, the disease, etc. And then we'll go into the specific role of tests in screening programs. How are we supposed to do to consider everything to apply the test for the purpose of screening a particular diseases in population. And then I'm going to talk about two groups of indicators, validity and reliability. There are two groups of indicators to evaluate the performance of the screening tool. I'll just tell you how good it is. And ROC Curve is the other tool we are going to use to evaluate the screening tools, especially when the outcome is a continuous variable. In the end, I'm going to talk about the relation between yield and prevalence. Of course, I'm going to tell you what yields means and the relationship between yields and prevalence as a screening tool by the data simulation. Biology is something fundamental for all the primary and secondary school, right? I believe that most of you have taken it when you are a child or a young kid. And the variation of human population is one of the assumptions for Darwin's evolutionary. Remember? In medicine or public health, we're trying to measure the exposure and outcome for population. So basically, they are also the biological measurements. But the precision and the repeatability might differ in various settings. Like what you know, that everything we observe in Mother Nature, the variation is much bigger than what we see in the other discipline in science. So it's kind of constant that the variation is much bigger for biology and also for clinical medicine. So which makes it more difficult to distinguish sick people from the others. There's no clear cutoff point to discriminate these two groups of people. Of course, at certain level, you'll find something difficult, and also it could always make mistakes, especially for the people who are apparently healthy. Even if you have very sophisticated and very expensive tools in hand, it's still possible that you make a mistake in terms of diagnosis. Also, if you want to apply such a kind of measurement in clinical scale, in a hospital or clinical setting, then it might be a little bit easier, because when people came to the hospital clinical, they might feel uncomfortable or something, or they worry about something, right? But if you want to do it at a population scale, most of them might be apparently healthy in the very beginning or at the specific moment you are going to screen for their diseases. So the uncertainty will be even higher, right? One of the assumptions that heterogeneity is the essential in populations. That's what we observed in the nature. So there are a lot of issues we have to consider about, like the characteristics of the study population, distributed in human population. That will be something we need to consider before we could start to apply a screening tool to detect diseases among the big population. So diagnosis basically is the tool we use in clinical setting. And what is the purpose of the diagnosis? Of course, it's for treatment, right? Without the diagnosis, not much we can do. We might just give them NSAIDs or aspirin, keep on observe. So if the patient shows some sign about infection, or maybe what we can do is just give them the first line antibiotics, something like that, and observe to see what happened. But if we could identify the disease status by diagnosis to make sure that the disease, they will be able to give the specific treatment in response to the specific disease. Generally, it works much better. But screening is another tool for us to discriminate people with or without the disease. But the performance of screening depends on many characteristics, and sometimes it's only applicable for specific purposes only. It's not something universally you could apply to anything in any population, which is not true. Okay, so what is screening? Screening is defined as the application of the test or procedure, sometimes takes steps, not only one step, to apparently well or so-called asymptomatic, no symptom at all, individuals to discriminate those with a relatively high probability of having the given disease from those with a relatively low probability of having the disease. But we do need to make the decision under such kind of uncertainty. So that's what screen. So relatively screening will be easier, cheaper, and less invasive, but quicker, but cheaper comparing to diagnosis. So make it more acceptable. So how are we going to choose the suitable targets for screening? The first thing to consider is the entity of the disease in terms of population. Is it a major impact to public health? Like TB. To most of the country, it is. Although the frequency is decreasing and the severity of TB is also decreasing because of the development of the new medications. But in most of the country, even in developed countries, TB is still a serious public health issue because it's the top cause of death from infectious disease in Taiwan. I do believe it's also true in most of the developing and developed countries. And myopia is a particularly important public health issue in Taiwan. So we do screen the myopia for kids every year, even every semester when I was a kid. So we have to do it in the very beginning of a semester. It's kind of a ceremony, part of the ceremony of the beginning of a semester to screen myopia. But it doesn't really help the percentage. The prevalence of myopia is still very high, over 90% in Taiwan. Okay, we do need to do something about it. Okay, and cancers. Cancers is generally one of the top causes or leading cause of death in most of the countries in the world. So, of course, it will be important in terms of the public health. But not AIDS. Why not? It seems pretty serious, right? And the frequency, it doesn't change too much, right? But why not? We are not supposed to screen AIDS in the population. In general, we don't screen AIDS to every single one. Unless someone had some dangerous behavior, right? Or drug user, or STD, or the STD patients, right? So only screen the high-risk group. Yeah, because the risk just vary a lot. And also the impact of the screen for AIDS is too strong. So we don't do it to every single one, not like myopia. So only screen the high-risk group. So how we consider such kind of issues that, yes, we are going to screen for TB, for myopia, for cancer, but not for AIDS to every single one. Okay, that's the key point for today. AIDS is a syndrome, is a group of symptoms. It's possible that positive for AIDS but negative for HIV. Yeah. But nowadays, most of AIDS is caused by HIV. Yeah. For the target of screening, it should have a reasonable, long, and recognizable pre-symptomatic stage. Like cervical cancer would be a great example. The pre-symptomatic stage could be as long as 15 or even 20 years. So if we could identify the sufferer of cervical cancer, it would be easy to deal with by surgery and plus some chemo or radiotherapy, and maybe not for chemo, for radiotherapy. Then the 5-year survival rate could be very high, higher than 95 or something like that. And also, it has to be true that the effective treatment is available. For cervical cancer, again, is a great example. And also the treatment should be more efficient if initiated at a pre-symptomatic stage, especially for cancers. But not all the cancers, but most of the cancers, it is true. Some types of cancer is very unlikely to identify at earlier stage without any symptom, like spleen cancer, which is so-called the king of cancers. It's pretty fatal. The 5-year survival rate could be as low as 5% or something. So the first thing about how to find a suitable tool for screening is reliability. It has to be reliable. You have to consider about the technical issues in the instrument, including calibration and training. So this is not only about the instrument itself, but also about training and management, about how to use the tool for screening to make sure that it's reliable enough to be applied as a tool for screening. Okay, and also it has to be sensitive and specific. So we are going to talk about later about the sensitivity and specificity. Those are the indicators for validity. And it has to be acceptable to the population screened. It could be non-invasive methods are preferred. Some people hate to draw blood, right? And some people hate to be touched by the other people. Some people hate to show or bring their urine or stool to hospital or something, right? So there are a lot of things. Of course, it has to be reasonably inexpensive and safe because we are going to apply the screening tool to the population, right? So the cost will be very high. So it will be better, cheaper. It has to be safe, even if the vulnerable group of people will not be harmed by the screening. Okay, because we have limited resources. And validity and reliability are two major groups of indicators about the performance of the screening tool. Validity is asking the question about how precise. The major ones are sensitivity and specificity. I'm going to define it later in the next slides. And also, with exact decimal information, we could generate the other indicator like a positive predictive value and negative predictive value. I'm going to talk about it in the next slide. But sensitivity and specificity are the essential ones. Positive predictive value and negative predictive value are less useful. Okay. And also, exact the same data, we could also identify the number or percentage of false positive or false negative. And reliability is the other group of variables to measure how repeatable of the screening or the test. The first one I'm going to introduce is Kappa, which is particularly developed for the categorical variable. The data is yes or no, or 1, 2, 3, or categorical. And the other thing is that if the outcome is a continuous variable and the best indicator for reliability is so-called intracategory correlation coefficient. I just need to know that with a continuous variable outcome, we cannot use Kappa to evaluate the reliability for the screening tool. So we have to use intracategory correlation coefficient. Okay, it's just an indicator, don't worry. For continuous variable. Okay, and the validity and reliability measurement could differ by the severity of disease and also the characteristics of the screen population. So it's not fixed. It varies by the population and also by the severity of the disease. If you are screening a group of people, there are more people with the disease, or the ones with the disease are more severe, then the validity might be higher, right? So it's not fixed. Okay. Of course, a great or a perfect screening tool should be low cost and non-invasive, blah, 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 and high validity, high reliability. That's for sure, right? But is it the worst scenario that low validity and low reliability? No. If there's a tool that's showing low validity and low reliability, we don't use it. We throw it to the bin, right? Yeah. Okay, but if it's a high validity but low reliability, think about it. Or low validity but high reliability, No, right? Yeah, so the worst scenario should be low validity but high reliability. So always, the tool always give you a wrong answer, right? That's the worst scenario. You're spending money to get the wrong answer all the time, right? So low is not the worst scenario. The worst one is low validity but high reliability. It just repeatedly give you the wrong answer, right? That's terrible. Here's the definition of how we consider the whole thing about the validity with several indicators. But first of all, it's a typical 2x2 table again. And let's assume that we have a clear idea. We have the very, very precise information about disease status, like this. Some people are having the disease, and some people have no disease. We knew it. That we knew the true value anyway. And here is the testing result, positive or negative. Okay? So if someone got the disease and tested positive, this is called true positive. That's straightforward. If someone having no disease and tested negative, perfect, that's true negative. Right? But that's the correct ones. What about the wrong ones? There will be two possibilities. The first one is someone having the disease but tested negative, so that's false negative, not true. And also it could be the other way around, that people having no disease but tested positive, that's terrible, that's false positive. Okay, that's how we define the four categories in the 2x2 table. Okay, that's the true value, and here's the test outcome. Okay. In a perfect situation, there will be all the ones with the disease are tested positive, and all the ones without disease test negative. Perfect. Okay? So someone developed the indicator called sensitivity. That's the number of the people who are true positive developed by the people having the disease. In other words, it's the percentage of the people having the disease tested positive. Is that straightforward enough for you? Okay, that's about the group of people having the disease. Okay, and the other indicator is specificity. It's about the group of people without the disease. So the ones without the disease, the percentage of them tested negative, so which is also correct one, right? So the perfect tool should be 100% for sensitivity and also 100% for specificity. Okay, so this is straightforward enough. This is the two major ones for the indicator about validity for dichotomous testing results. Now, what is so-called positive predictive value? It's pretty straightforward, right? Positive predictive value. So positive is the group who are tested positive, right? Predictive value means that the percentage of the one who are shown who is really having the disease. So it's true positive divided by people tested positive. Okay, you don't even need to remember the formula, right? You can figure it out by the name of it. Oh, that's great. Also, for negative predictive value, it's the same. It's the true negative, the percentage of true negative among the people tested negative. So it's a calculation in this direction, right? And sensitivity or specificity is that direction. So let's assume that we know the disease status, and then we apply the screening tool to the population. Then we could generate these four indicators to show how good it is. So it'd be, if it's a perfect one, 100, 100, 100, 100, right? So if it's not so good, it may be high for sensitivity, low for specificity, or low specificity, high sensitivity. So we show different situation. Okay. In the consideration of validity, we need to assume that we know the gold standard. It's the basis of evaluating the testing rules. It's just like the answer for exams, right? Without it, it will be hard to do the scoring, right? So for example, biopsy is the gold standard for the diagnosis of cancer. So we check the pathological exam output report to make sure that the disease status for cancer. Or in the classical way of the microbiology, we use incubation of a specific microorganisms to do the diagnosis. That's what we did for the diagnosis for TB years ago. Okay, but nowadays, because of development of the genetic technology, we could use the DNA methods. That's what we do for influenza screening now. Yeah, but some viruses, they got RNA only, right? So we do real-time PCR, polymerase chain reaction, real-time RCT, chain reaction, PCR, RT-PCR, right? That's what we do for the diagnosis or screening for COVID-19. Okay, so those are the genetic technology, etc., etc. So we could consider those as the gold standard. But false positive will waste the more sophisticated and expensive test afterwards. So false negative might not be so terrible because, but actually it depends on the severity of the disease. But false positive will waste a lot of money and also sophisticated test, which might be expensive. But false negative might cause poor prognosis because he or she missed for this time of screening. And maybe 2 years later, he or she will be screened positive or he or she become diagnosed because of some symptoms. So that'll be worse. Then the prognosis might be poorer, especially for severe diseases like cancer. So we have to consider the whole thing to keep the balance, to find out the balance point between sensitivity and specificity, because it's a trade-off. If you are trying to enhance the sensitivity somehow, you might change the criteria to define the cutoff point, right? To enhance the sensitivity, then specificity will generally goes down. If you want to increase specificity and sensitivity, generally going down. So it's so-called a trade-off. It's hard to find the best point to keep the balance between sensitivity and specificity. So that's the situation when the outcome is a dichotomous one, disease, non-disease. Okay. But what if the outcome is continuous test results, like blood pressure, systolic, diastolic blood pressure, or glucose level in the blood? Then we need to find an optimal cutoff level for decision making. If the outcome is a continuous one, then we might need to find the cutoff point, like the definition of obesity. Why is it 30, right? Or 25 as overweight and obese? Those are the cutoff point for a continuous variable. We need to use it for decision making. Okay, then we use a tool called the receiver operating characteristic. It doesn't really make sense, right? But ROC does make some sense. Republic of China, the country, the official name of Taiwan. Curves are commonly used to show sensitivity and specificity of a test at all possible cutoff values. So let's just assume that we know the disease status, okay? And then we just use the cutoff value from the minimum to the maximum. And then every time you cut it, you could generate a set of sensitivity and specificity, right? So even if someone got diabetes, it's possible that his or her glucose level very low. That's so-called hypoglycemia, right? If even someone got hypertension, his or her blood pressure level could be very low because of shock or something, right? Or infection, right? Okay, so even if someone got the disease, which is a sure thing, it's not definitely true that he or she got a high level for some levels or something, right? So we use the ROC curve, receiver operating characteristic curve, to show the general feature about the screening tool, which generate a continuous variable. Then the horizon axis or x-axis is 1 minus specificity or false positive. That's weird because we are talking about sensitivity and specificity. But why is used 1 minus specificity, which is showing the false positive? Because that's part of the tradition. Years ago, when people started to use the tool ROC Curves to find out the optimal cutoff point, that old guy or old lady decided to use it. So that's why we have no choice to accept it. That's for x-axis. Now y-axis is simply sensitivity. Okay, so it's very straightforward. Okay, sensitivity and y minus specificity, which is false positive. Okay, then we could apply those kind of the idea here to show the comparison of different tools by such a simple figure. The best part of it is that in one single figure we could combine the sensitivity and specificity at different cut point in one figure. So it's very straightforward for you to eyeball which one is better than the other. So here is the y minus specificity, and here y-axis sensitivity. Now what about a perfect tool? No matter how low your blood pressure is or how high your blood pressure is, there's a tool. Imagine that there's a tool always give you 100% for sensitivity and 100% for specificity, no matter where you do the cutoff point. There'll be a straight line here and then straight line there. That's a perfect screening tool. Okay, but it doesn't really exist. Okay, so the worst ones are closer, lower and lower. Then what's the worst one? That's the diagonal line. If you apply a screening tool to give you a continuous variable, and then as an outcome, but it's very close to the diagonal line, then it's not a good screening tool. Okay, but if it's exactly the diagonal line, then it's just simply random. A dog or a cat or a monkey can do exactly the same job or even better, right? But if the line is lower than the diagonal line, then that's even worse than not using the screening tool for the screening of the particular disease. Okay? But anyway, you just need to remember the higher the better. Okay? So here's a figure to the comparison of 3 screening tools, the green dash line and orange line and blue dash line. Yeah, so which one is better than the others? Not so easy, right? But under the 40% of the false positive, apparently the blue one and orange one is better than the green one, right? And over 40, the green line looks better. Yeah. So generally, how can we do the comparison? We could estimate the area under the curve to do the comparison. Okay, so it becomes a continuous variable, right? So the best scenario will be 1, right? Area under the curve, or is the space, the area under it. The worst one will be 0.5, right? Just fit on a line fitting on the diagonal line. If we can compare their area under the curve, then we could make the decision that which one is the best. Okay, and here's the other example. These are the real data, 3 lines, but they are very close to each other. So even if you try to use the area under the curve to compare these 3, we might not be able to find any differences. Anyway, but all the ROC curves are like this. They are a curve from this corner to that corner. And the best one will be shoot. Worst one will be the diagonal line. So generally there are lines between this area. The higher the better. Okay, that's what you need to know about ROC curve. So it's kind of a comprehensive way to show you the sensitivity and the specificity at different cutoff point for validity. Okay, so let's talk about reliability. That's a different aspects about how good the measurement or the screening tool is. Reliability is defined as the degree of consistency. So if you do it twice, is it tell you exactly the same answer? Among measurements on the same person. So now we are talking about the same person. But even if you measure your blood pressure for twice at the same time, it's very unlikely to find exactly the same readings, right, or figures, right? But generally speaking, if someone got a hypertension, then generally speaking, his or her blood pressure will be higher than normal, right? There are several kinds of reliability. If we are talking about the consistency of the test repeated on a person, that's intra-subject reliability. Intra, subject is you, is that person, sorry, not you, that person, intra-subject. Or if we are talking about the consistency of tests repeated by an observer, the same examiner, it could be physician or nurse, then the reliability is so-called intra-observer reliability. And if we are talking about the consistency between observers, that's inter-observer reliability. That's more important. So we are going to focus on intra-observer reliability to show you how to do the calculation for overall percent agreement and Kappa. Those are the two indicators used to evaluate the reliability, especially for inter-observer reliability. But I can tell you that Kappa is better than overall percent agreement. You need to know why. Percent agreement is pretty straightforward. So that's considered you have two observers or two physicians checking people for their disease status or screening people for their existence of a specific disease. But please make sure that there's no true value here. It's not like a sensitivity or specificity. We assume that we already know the true value, but there's no true value here. Sometimes it's very difficult to find a true value, even if that's the path report. So it could be the pathologist 1 and the pathologist 2. Okay? So they check the sample from the total number A plus B plus C plus D. So many people. Okay? And of course, they will find some A number of people who are both positive by the different observers, right? And also D number of people who are both negative by the two observers, right? And B or C will be the inconsistent ones. Okay, so the percent agreement should be very straightforward. So A plus C divided by the total number. Okay, that's the idea of percent agreement. Yeah, but some people may argue that, but D doesn't really mean anything. So if we just ignore the D number, so in the paired observations in which at least one observation in each pair was positive, so if we only taken care of the A, B, and C, then the percentage is so-called overall percent agreement. That's the kind of preliminary or primitive indicator about indication 20 or 50 years ago. But some people argue that this is not really making sense because the consistency could happen by chance. Okay, so some smart people developed Kappa, which is an indicator about consistency, getting rid of the consistency happen by chance. Okay, so it's kind of a procedure. So just follow me step by step. Kappa is a statistic to measure the degree of agreement between observations. So that's why inter-observer reliability, right? Beyond the level of agreement expected by chance. So now we want to get rid of the agreement happened by chance. Even if we give exactly the same information to a pathologist and a doc, of course there will be some consistent identification outcome, right? It could happen by chance, right? So how can we get rid of the issue about something happening, the consistency happening by chance? Yeah, Kappa will be the indicator. And the best thing is that it's a pretty straightforward. It's a number ranging from -1 to 1. So if it's excellent agreement, then the Kappa should be higher than 0.75. Good agreement, 0.4 to 0.75. If less than 0.4, then we call it the poor agreement. What about 0 or minus? Then I don't know. That's even worse than without doing it, right? Yeah, but you might ask me, why 0.75, 0.4 here? Yeah, it's kind of arbitrary. So it's rule of thumb again. Okay, There's no reason why. Yeah, but you just need to know that the kappa is a very simple indicator from -1 to 1. And the best scenario will be 1. But if it's higher than 0.5, that's good enough in terms of the consistency between two observers. Okay, so let's start with the real figures. Let's consider the issue that we have totally 75 people experience the test or examination by two pathologists, pathologist A, pathologist B. And for the pathologist A, he or she just identified that 45 people is grade 2, okay, and the other 30 are grade 3 for the stage of cancer. And also for pathologist B, he or she identified that 44 people is at the stage of grade 2, and 31 is grade 3. Okay, then we could check the details about the consistency that 41 is also grade 2 from both of them, and 27 of them are in grade 3 from both of the pathologists. But there are some inconsistencies. Right? Here, the pathologist A said that, that's grade 3, but the pathologist B said that, that's the grade 2 only. Okay, and here the same, there are inconsistency here. Okay, so even if both of them are trained as a pathologist for many years, it's possible that it's not consistent, right, to each other. The results are not consistent to each other. Okay, so how are we going to calculate the kappa in such a situation? We have to calculate the percent of agreement. 41 plus 27 divided by 75. Okay, very straightforward. Percent agreement. We just take care of the percentage of the consistent one among all of the people screened or examined. Okay, and then we have to do the calculation like what we did for chi-square estimation. Okay, anyway, I can show you this how we get the expected number of the consistency here. It could be either 45 times the probability, the percentage of this, 58.7, they got 26.4. Okay? If this group of people got the same percentage of the total, got 26.4. Exactly the same thing, you could get this. This times this divided by that. This times this divided by that. This time this divided by that. So we got the 4 expected value. Then we calculate the percentage agreement by the expected by chance alone. So again, it's 26.4 plus 12.4 divided by 75. Then we got 51.7. This is what happened by chance alone. This times this divided by this, we got this. Okay, this times this divided by this, we got that. This is so-called percentage of agreement expected by chance alone. And then do exactly the same calculation like what we did in the previous slide. And the kappa is like this. Now you have the components you need to do the calculation of kappa. P0 is the previous one, the agreement. The percent agreement, P0 is this one. This one. Okay, the expected one, we call the PE, expected one. Percent agreement expected by chance alone. Okay, so we have the P0, PE, the difference between them, divided by 1 minus PE. Okay, so both of the numerator and denominator got the PE. That's the part has to be taken away from the calculation. So P0 is observed proportional agreement. PE the expected one of it in the previous slides. Okay, then we could do the calculation for kappa, and then you'll figure out that the kappa is as high as 0.81, which is pretty good. Okay, if you do it in computer, it will also give you a 95% confidence interval by the methods of unbiased estimation. Okay, plus minus 1.96 standard deviation, remember? Then we have to take the the probability happened by chance away from the numerator and denominator, and we got it 0.81. Yeah, it makes more sense because it's just getting rid of the consistency happened by chance. This happened by chance because it's 0.81. So this is the best ever indicator about consistency in epidemiology, to evaluate a screening tool for consistency. So this is pretty good. In other words, that these two pathologies are trained in a pretty good way, right? So they could give you a pretty consistent outcome. You don't need to worry about something happened by chance. They are not two monkeys. They are two experts, right? Okay, so that's high. So now let's think about the prevalence. Remember, in the very beginning, I said that the characteristic of population is one of the key issues about the performance of the screening, right? And yield will be something about the absolute number of people who are screened positive. So yield is defined as the number of cases detected and treated, or not only detected but also treated. If someone was detected positive, but he or she just choose to ignore it or refuse to do anything, then it's not counted in yield. Yield would be a number more about the management or health policy, not really about epidemiology. It's not a proportion, it's just simply an absolute number screened positive and taken into the treatment process in a clinical setting. But a screening program in a population without apparent symptom of that disease. So that's the definition of screening, right? So yield is the number of people who are tested positive and also accept what we offer for the treatment for the disease. So it's not a probability or relative risk or something like that. It's simply an absolute number of people. So screening in a population with a high prevalence of target population will definitely get a better yield, right? We'll identify more people with the disease, right? With less false positives, because with a higher positive predictive value. If the screening population, the prevalence of the screened population is higher for the disease, then we are expecting to have a better yield and less false positive, and also at a high positive predictive value. That's pretty straightforward, intuitive. It's kind of the relationship. But is that always true, or it just change over the situation or different level of the prevalence? We are going to show you in the next slide. So if we are having a better screening tool, or in other words, got a higher sensitivity, but it might not always give a better yield. So it really depends on the characteristic of the population or the severity distribution in the population. If most of them are less severe, then it might not be so true. So we use the method of the data simulation. We find out that the relationship is not a linear line. So when we are seeing this kind of figure, the first thing is to understand what is going on for the axis. What's the meaning of the axis? The x-axis is the prevalence of disease in percentage, and y is the predictive value percentage. So that's why there's a positive predictive value, negative predictive value. Like what I said, if the prevalence of the disease to be screened, along with the increase of this, we got a higher positive predictive value, right? That's very straightforward. But the negative predictive value is dropping, but it's not linear. Okay. So now the key point is how to find out the best point to have the best positive predictive value, but not so bad for negative predictive value, right? Because the negative predictive is dropping, right? So maybe it's about this area. So this will give us some idea about which kind of population would be the best target to be screened. Maybe the prevalence is about 40-something, right? Maybe not so useful when the prevalence is so low in this population, in a population, not this, sorry. And for a population with a very high prevalence, you're expecting a very high positive predictive value and good yield, but the negative predictive value might not be so good, right? It's kind of dynamic. Now we have several issues going on here, right? Yeah. So this will be another tool to show us the characteristic of the screening tool, which depends on the prevalence of disease. Okay. This is called data simulation. Personal insight. Screening is a critical tool in preventive medicine. Right? The earlier we can identify the disease, the more efficient we treat them. Right? So it's very important. But today I just give you some idea about very simple idea about a screening tool. But if we go into the specific characteristic of the study population, it could be very complicated. And that's the study more about. We are trying to identify the most appropriate population. They might fit into a very specific age group with a very specific gender and with some kind of chronic disease as the background to identify, to make sure that what is the best screening tool and what is the criteria which is optimal for that population. And screening tools are merely acceptable, but it cannot be perfect. Nothing could be perfect. Even the diagnosis method is not perfect. Even the path report, the gold standard, is not perfect. The only thing we can do is to assume that we know the real disease status to consider as gold standard. And then we could generate the indicators about how to evaluate the screening tool. And always consider the cost versus rewards when you are doing the decision for screening programs to the population. That's very important, especially the authority, right? If you are the member of the public health authority, you need to make such kind of decision. So you need to have some idea to communicate with the field worker, right? To the commercial companies, right? And also the physicians and the people working in the primary care, secondary care. That's why it's important. It's not only about money, it's also about science. It's also about humanity, right? They have to be acceptable, not so invasive, and people are willing to take the treatment, even if they don't feel anything, they don't have any symptom, right? But how can we convince them? They said, I don't feel anything, I don't have any symptom. Why do I need to do the treatment for cancer, right? Yeah, because we know the natural history. If you don't, then we will see, we know what will happen. Right? So we need to provide them information and do some health education, right, to convince them to take the appropriate treatments at earlier stage. The consideration is about money, about humanity, about epidemiology, but also epidemiology plays some role here for the issue of self-selection. People choose to take the screening program, right? You cannot enforce every single one to join it unless you are Kim Jong-un, right? Or someone, dictator can do that. But we cannot do that, right? So they've been selected, self-selected to join your screening program, right? So there's an issue of what? Potential selection bias. But don't jump that far. It's not definitely a selection bias. It happened by different mechanism, right? For most of the screening project, it's kind of cross-sectional. It's not a core study, right? But for some study, it's a follow-up study or protective. The mechanism for the generation of selection bias is different. You have to consider the whole thing. Like something I told you in the previous lecture about selection bias. But self-selection is a sure thing for any screening program, right? But it does not necessarily cause selection bias, but it definitely cause information bias, right? But it happened by different mechanisms for different study design, right? Remember that. Like the ones who are screened positive, but eventually find out that no disease, will he or she join your second screening again? No, right? You will hate every one of you working in the project, right? Because the suffering, the anxiety because of the positive test outcome. So that's that issue of the selection bias for core studies. Remember? Yeah. Okay. Read my lips. Validity and reliability for a screening tool differ by various conditions. Okay, and you need to know the indicators we use for validity and reliability. The most important one will be sensitivity, specificity for validity, remember? Okay, and also the ROC curve, if the outcome is a continuous variable. ROC curve, how we're going to use to compare different screening tools in the same population. Okay, and reliability, Kappa will be the most important one. It's the best ever tool for the estimation of consistency, because that's the only one which we could use to exclude the consistency happen by chance. Okay, we're not hiring monkey, we're hiring experts to do this job, right? So of course, we're expecting to have a high consistency to make it a good screening tool, right, or diagnosis tool. So sensitivity and specificity is the most important one, and also you need to know what is so-called positive predictive value and negative predictive value. All of them are pretty straightforward, right? Yeah. But if you do the screening for 2-stage, that'll be a little bit more complicated, right? So if something which is the outcome is so shocking, like HIV infection screening, then we might need to use the 2-stage. Only if someone got a positive in the first stage and a positive for the second stage. We make the conclusion, it's very likely that this one got HIV infection. But first of all, you need to have a clear idea about what is so-called sensitivity, what is so-called specificity, and how to calculate these two indicators. Okay. And positive predictive value and negative predictive value are pretty straightforward. Okay, but it's more useful, I mean, PPV is more useful in machine learning or the algorithm, the computer science. They prefer to use PPV and sensitivity as an indicator for their robots, for their artificial intelligence tools. Yeah, but in epidemiology, we care more about sensitivity and specificity. Okay, and we combine them together as an assessment of or evaluation of those tools by ROC curve. Okay, so sensitivity and specificity will be the essential ones. And ROC curve is a tool which provides a dynamic view on assessing screening tools with a continuous measurement of outcome. Okay, so that's why it's very useful. If you suggest a new biomarker in the blood for the diagnosis of cancer, what is the best way to do it? To find a group of people, and some of them got the cancer and some of them don't. Right? Then you can use the ROC curve to show how good your new biomarker works. Right? And can you raise a screening tool for a type of cancer as an example and talk about the pros and cons for it? Okay? After you learn everything, you should be able to do that. Right? If you don't know much about cancer, just Google it. You just need to have some common sense level information about cancer. I do believe that you could say a lot of things like this. Right? So that's the so-called the sense, right? Epidemiological sense in screening for serious diseases. Ways to think. This is a true information. The U.S. Preventive Service Task Force, USPSTF, recommends screening for colorectal cancer in adults using fecal occult blood test, or FOBT, just simply test the trace of the blood in the stool. Sigmoidoscopy is about this long. And what's that? A colonoscopy is that long, about 1 meter. And beginning at 50 years of age. Okay, why 50? Why not 45? Right? And continue until 75 years of age. What happened? Why not after year 75? Yeah, that's weird, right? But how did they make such kind of decision? Yeah, they perform a lot of study. They perform a meta-analysis or systematic review to find out the best cutoff point to identify the high-risk group. Yeah, but there are 3 options here: one for FOT, one for sigmoidoscopy, one for colorectal colonoscopy. And which one is the most non-invasive one? FOBT, right? You just test. You just do the test. You can do the sample at home, but you have to bring it to the clinic or hospital. Then the lab, a wet lab there would do it for you. And it's not possible to do it for a sigmoidoscopy or colonoscopy at home, right? So you might need to experience the terrible process to clean your guts, and then you could do colonoscopy. And sigmoidoscopy, because it's short, so it's likely to do it in a kind of without well preparation. Just clean the rectum, then you'll be able to do the examination. Okay. So first of all, why colorectal cancer? So you need to know something about the public health importance of colorectal cancer, right? That's the top one cause of the incident cases in Taiwan, and maybe for most of the developed country too. Incidence is so high, but mortality should be the third one, I think, in terms of mortality. Okay, so we have no doubt about the public health importance for colorectal cancer for most of the country in the world. Second, is it early intervention highly effective? Early intervention, if someone was diagnosed with colorectal cancer at in situ or stage 0 or early stage 1, is it available to find the intervention or the method of the treatment? But nowadays there are a lot of the surgical method has been developed to make sure that the early stage of colorectal cancer could be almost 100% cured. But it's available, and we are pretty sure about that. Surgery and also combined with radiotherapy might help the people at very early stage of colorectal cancer for almost 100% for survive. Okay, so it's true that it's available. Yeah. And the third part is a high-risk group. Do you know any people who are at a higher risk of colorectal cancer? Yeah, family history. Smokers, yes. Yeah, smoking is always a risk factor for almost all the cancers, right? And who are at high risk of colorectal cancer? Drinkers, yes, and also diabetes. Yeah, diabetes and obesity are two of the major causes of the colorectal cancer. And what about the lifestyle issues? Yeah, and red meat, right? Yeah, if you eat more red meat, and also vegetable consumption, and deep fried food. That's so available, I know. Anyway, we already know a lot about the high-risk group, right? So it's more efficient to do the screening project, to apply the screening method to those people? Yes. So they have different criteria for age. Okay, so they might get the medical insurance reimbursement at the earlier stage if he or she got a family member having the diagnosis of colorectal cancer or family history. And because they do the stratified analysis for different group of people by gender, by age, that's why they make the decision of overall screening or non-selective screening for the people over 50 until 75. So after 75, do people still need to be screened for colorectal cancer? Yes, but not so often if he or she has been proven no disease until age 75. Maybe the interval could be longer because we have a pretty good information about it to make the decision. That's why we need to learn epidemiology, right? And also the epidemiology research outcome combined with the cost information, we could do health economic evaluation or cost effectiveness evaluation. That's how we make the decision, right? Why beginning at 50 years old and continue to 70 years old only? Okay, because a series of studies has been done by different kind of ethnicity, different country, different situations anyway. That's the best thing, the best choice for American population. The last question is, how did they identify the optimal intervals for screening suggested? Now that's the PhD dissertation topic for one of my classmates about colorectal cancer screening interval. Why we suggest the ones with polyps, which is one of the precursor of colorectal cancer, to do the colonoscopy every other year, because they're high-risk group again, the one with the polyps, especially the people who have the family clustering. Okay, so this is a really important question to find out the best or the optimal intervals for screening for the people with different situation, different age, different family history, or different drinking or obesity, blah, blah, blah. Okay, so we could refine the project to make it more efficient and less suffering, a minimal cost, but the best yields, right? Okay, so that's the, so for all the serious diseases, you could do exactly the same thing to think about it. This will be very helpful for you to get a high score for the final examinations. Thank you.